Hi, this is a video on the non-invasive diagnostic approach for endometriosis, ultrasound, a webinar for the BSGE and Fertility and Sterility. My name's Suzanne Johnson and I'm a gynaecologist from Southampton. There are long delays in the diagnosis of endometriosis, and worldwide it's currently around 8 years. Many women consult their GPs many times before they're referred, and it's not quite clear what causes the delays. There is significant overlap with other conditions like irritable bowel syndrome, and there are some issues around the normalization of pain in patients and by their healthcare providers. But also, there's a myth that you cannot see endometriosis on ultrasound. This is just not true, and I hope to show you how. These are some examples of deep endometriosis that was easily seen on ultrasound. So a routine pelvic ultrasound mainly looks at the uterus, and you'd look for adenomyosis, the ovaries, ovarian endometriomas, but you also need to look for deep endometriosis, need to look for mobility, to look for a frozen pelvis, and for site-specific tenderness. Superficial endometriosis will be covered separately. The National Institute for Health and Clinical Excellence published this guideline in 2017 on the diagnosis and management of endometriosis. And you'll see that in the very early stages, they would just say, consider an ultrasound scan. And after some initial treatment and management, the patient might be referred to a gynaecologist, where the gold standard for diagnosing endometriosis is laparoscopy. So a laparoscopy is where we put a camera through the umbilicus looking toward the patient's feet into the pelvis. And this is a little video clip of a normal pelvis. So it's the back of the uterus, a nice big gap between the uterus and the bowel, and you can see the ovaries and the fallopian tubes. But in a patient with deep endometriosis, this is what their pelvis might look like. The back of the uterus, the ovaries, the tubes, bowel, everything is adherent to each other. It's quite hard to see exactly what's what. This is called a frozen pelvis. The International Deep Endometriosis Analysis Group published this paper in 2016, and it gave us both a language for how to describe endometriosis as well as a system for how to perform such a scan, and these 4 steps can be done in any order. Language really matters, and the idea terminology was very clear that if you draw a line through the internal os and the torus and a line below the cervix, then the area between the vagina and the bowel is called the rectovaginal septum. The bit of vagina above the red line where it attaches to the cervix is the posterior vaginal fornix, and then there's the pouch of Douglas between the uterus and the bowel. The bowel below the torus, below the green line, is the lower rectum. The bowel above the green line, above the torus, is the upper rectum, and then bowel above the level of the fundus of the uterus, it would be called sigmoid. The posterior compartment is affected by deep endometriosis, and common locations are in the posterior vaginal fornix, at the torus, in the lower rectum, in the upper rectum, and it can all become adherent together, and this is the frozen pelvis. So in the posterior compartment, there's the vagina, the ligaments, and the bowel. But the anterior compartment is another common place for endometriosis, in the bladder and in or around the ureter. So before you start your scan, you need to have enough time to do the scan. 30 minutes for a standard scan is a good amount of time, 45 minutes for a detailed pelvic scan, as I'm going to describe to you. You would start the scan transvaginally, unless you're specifically looking for fibroids or the patient is potentially virgo intacta. And you start the scan with the patient having an empty bladder and no bowel prep. You need to make the patient feel comfortable, lock the door, cover them over, be nice. And then use a bed, not a wedge. Have the patient's bottom at the edge of the bed and the bed slightly high. And then feet on the stirrups or on a chair. And if the patient has got stirrups, you can sit between the legs, and this is a good position to look for deep endometriosis. You need to be super gentle with patients with endometriosis because they've already had a lot of pelvic pain, and explain what you're going to do and get consent. And I warn them in advance that when I'm quiet, it just means I'm concentrating, and I say, I'm so sorry, but I can't talk while I scan. And then I ask them to put their arms by their sides, let the bottom sink into the bed, and let your knees go floppy. This makes a huge difference. Then gently and slowly insert the probe with plenty of lubricant on the outside of the probe, angle the probe backwards toward the sacrum, and do a normal systematic pelvic ultrasound. In patients with endometriosis, I would also do a renal scan. That's because around 3% of them have silent hydronephrosis. The probe orientation, just to show, this is my orientation so that the uterus is here, the bladder is there, and the bowel is behind there. Some colleagues scan the other way around. So the idea ultrasound, this is how I do it. I start off with a systematic routine pelvic ultrasound looking for features of endometriosis. Uterine position is something we just need to quickly talk about. This uterus is anteverted and anteflexed. This one is retroverted and retroflexed. This uterus is anteverted, but it's retroflexed at the internal os. And then this uterus is axial. So what can we look for in this scan for endometriosis? We're going to look specifically for an anteverted but retroflexed uterus. And this is the position it's in because it's being pulled backwards by adhesions. This is also called the question mark sign, and that was as published by Nadine Di Donato, where she found it was associated with adenomyosis. The Musa group published this paper in 2019 on the sonographic classification for adenomyosis, and you can see some features like a globular uterus, asymmetrical thickening, some small myometrial cysts, some hyperechoic islands, fan-shaped shadowing, and sometimes some very early budding you can see there. The Doppler shows a translesional vascularity as compared to fibroids, where it tends to be peripheral, and you might see an irregular junctional zone or an interrupted junctional zone, and these are more subtle. So this is what it might look like on ultrasound. Here you can see a bulky uterus, anteverted and anteflexed uterus, bulky uterus with a very indistinct endomyometrial junction. It's hard to see it at all. The endometrium is about there. And you can see these little small myometrial cysts. You can see a lot of stripy shadowing. And this is a diffuse adenomyosis. Some other times you can see islands of endometrium in the myometrium. You can see this clearly here. This is severe adenomyosis. And you can put your 3D on, and then you would see an irregular endomyometrial junction with all this budding that you can see, an irregular junctional zone. Next, we'd look at the ovaries for ovarian endometriomas, and the IOTA group have described an endometrioma as a unilocular cyst with ground glass echogenicity contents. It's usually unilocular. It can be up to about 4 locules, and you'll see that this ovary sits very low in the pelvis. If you then go transversely, you can see that in fact this endometrioma is adherent to the back of the uterus quite low. And if you compare that to the mobility of the other ovary, this is freely mobile, as you can see there. So you can see there's an endometrioma and there are uterine adhesions. The other thing you need to look at for endometriomas is whether the ovaries are kissing, and this is in the transverse plane, of course, a bit of uterus at the front. This is a ground glass echogenicity. This one is anechoic. You can get anechoic endometriomas, and you can see that these ovaries are adherent to each other. They're also adherent to the back of the uterus. It's important that if you see endometriomas that you look for deep endometriosis, and this we learned from Katerina Exokoustos. And many people, even if they don't know how to look for endometriosis, will notice a low ovary. So when you see a low ovary, you can see it's at the level of the torus. Rotate your probe transverse and gently press, and you can see this ovary is at least sitting on the uterosacral ligament, if not actually adherent to it. You'd have to see a video clip. Another thing we look for, of course, is a Hydrosalpinx in between the uterus and the ovary usually, or maybe near the ovary elsewhere. And this is in a longitudinal and a transverse plane, and this is a little video clip of that Hydrosalpinx. It's probably more of a hematosalpinx. You can see that the contents are low level echogenicity, maybe ground glass, and you can see that there it's attached to the ovary with a small endometrioma. So this again is the unilocular Hydrosalpinx. It's very big. It's adherent to the left ovary with a little endometrioma, and the other side's a big endometrioma. And you can see that it's attached to the ovaries before you can even see the uterus, so you know that this is all very low in the pelvis. There's the uterus. So having done a systematic routine scan, I then look for the sliding sign. So the sliding sign, this was published by various authors in 2013, and it's a really good addition to a routine scan. This is an anteverted uterus. My probe is in the anterior fornix, and you can see how beautifully the uterus moves. The uterus moves one way, and all of the bowel behind the uterus moves the other way. So the bowel is freely mobile on the back of the uterus, and this is a normal sliding sign. And I'm doing this by I've got my probe in the anterior fornix. I'm very gently pressing in and out a tiny bit with the probe, and only rarely do I need to use my other hand on the abdomen to ballot between. Usually just a little bit of gentle movement there is enough. So then this is an abnormal sliding sign. Here you can see, again, I'm pressing gently with the probe, that things move, but it all moves together. The uterus with adenomyosis, the bowel, an endometrioma, everything moves together. This is an abnormal sliding sign. So in a retroverted uterus, where the uterus points toward the patient's feet, you can see here a little bit of free fluid, which is super helpful, that the bowel moves freely on the back of the uterus. That's where the torus is, just at the top there. And you can see this is free movement, so a normal pouch of Douglas. And just to compare with an abnormal sliding sign, this is an abnormal sliding sign. You can see that the bowel is adherent to the back of the cervix, to the back of the uterus, and there's no movement there at all. So we should really add the sliding sign to every routine pelvic ultrasound. It's quite quick to learn. You just have to concentrate and repeat it. And once you know how to do this, you'll make a huge difference, because this raises a real suspicion of the presence for endometriosis. Next, though, we look for nodules of deep endometriosis. And deep endometriosis is when the lesion extends for more than 5 millimeters underneath the peritoneum. You then get cyclical bleeding, which results in inflammation and fibrosis. You end up with these little dark hypoechoic nodules that are surrounded by bright white fibrosis. That's what we're looking for. We can find those in the posterior and the anterior compartment. And so if we're looking in the posterior compartment first, look behind the uterus. And on this little diagram of mine, you can see here that the probe is in the anterior fornix. This is the view you get looking through the cervix. But if you put your probe in the posterior fornix, you look behind the uterus. You can't see the cervix, but you can really see the posterior compartment very well. That's what we need to do. So a vaginal fornix, what are we talking about? This is a normal posterior vaginal fornix. There's a little bit of air in there. That is the level of the torus through the internal os. And I'm going to show you that my probe is in the anterior fornix. I'm going to show you the anterior lip of the cervix posterior. And this is the vagina. This is the point where the posterior vaginal fornix attaches to the cervix. So I'm in the longitudinal plane, just going from side to side, just showing you what the normal posterior vaginal fornix looks like. Just like that. So how do we get from the anterior to the posterior fornix? We need to withdraw the probe a little bit from the anterior fornix, angle it slightly further backwards while encouraging the patient to let her legs go, her knees go floppy, and then it's quite straightforward. And if you're gentle, this doesn't hurt at all. So we're just in the longitudinal plane. I'm in the anterior fornix. I'm going to withdraw the probe a little bit, angle my probe backwards, and here I'm very gently inserting the probe into the posterior fornix. And so the vagina is now overlying my probe, and there's a little bit of free fluid, which is always super helpful. You can have a good look around. There's some peritoneum and some ligaments, a nice reflection of the pouch of Douglas just there. And here we are in the anterior fornix again. And you can see how when we were in the anterior fornix, we could see the cervix, but when we were in the posterior fornix, we couldn't see the cervix. So what does fornicele deep endometriosis looks like when the vagina itself is affected by deep endometriosis? This is what it looks like. You could see there's a bit of normal vagina, normal, and then this bit of vagina is affected by deep endometriosis. You can see it there, little areas of hemorrhage within. And this is what it looks like on a speculum examination. You can see that there's the little bluish tinge of blood vessels in this slightly irregular nodule there. So you might look for DE in the vagina itself, but also in the ligaments. And this is a very common place for deep endometriosis. So what are we talking about? The torus and the uterosacral ligaments. This again is the view at laparoscopy, where this side of the patient is her right, because we're looking toward her legs. It's the other way around to an ultrasound. Posterior aspect of the uterus. This is the torus, and the torus is where the uterosacral ligaments insert on the back of the cervix. So this is torus, right uterosacral, left uterosacral ligament, and these tissues become affected by deep endometriosis very commonly. This is the pouch of Douglas. Just here, there's the space between the back of the cervix and the vagina and the bowel, which is just out of view there. So deep endometriosis. So first you need to get good at visualizing the torus. So we're going to be in the longitudinal view of where the bladder tissues attach to the uterus, internal os, torus. I'm going to go side to side a little bit in the longitudinal plane. Then I'm going to rotate on this point, and that will show me the torus, and that's where those uterosacral ligaments attach. So I'm looking at the torus, and I'm now going to slightly go side to side, make sure I'm in the right place. I'm going to rotate round. This is now the torus. The torus is here at the back. This is one uterosacral ligament, and this is the other. They're very hard to see when they're normal because it's just a very fine white line like that. Those are the uterosacral ligaments seen through the anterior fornix. This is then what normal would look like. So this is the torus here. This is the torus and transverse with normal uterosacral ligaments. But it's very clear when they're not normal. Here you've got dense retrocervical fibrosis, and this dark area within, this is deep endometriosis, either in the torus and or the uterosacral ligaments. And in the transverse plane, it looks like this, and you can see this very dense, thick fibrotic ligaments. So these are the torus and the uterosacral ligaments seen through the anterior fornix. This will be quite striking when you first see it. You can see the uterosacral ligaments through the posterior fornix. So here the probe is in the posterior fornix, the cervix is up there somewhere. And I'll show you in a minute, this dark line is the vagina, this white line is the peritoneum. And in a moment, the uterosacral ligament will appear at this angle. And as I advance my probe onto it, the uterosacral ligament becomes applied to this. So the white line is then peritoneum and uterosacral ligament. I learnt this from one of Sophie Pearson's YouTube videos. Very good indeed. So this is me now doing the scan myself. And there's the uterosacral ligament becoming applied to the peritoneum. And there it goes again. You can't always see the ligament as nicely as that. It helps when there's a little bit of fluid. So that's the vagina, that's the peritoneum, and that's the uterosacral ligament. And so when you have pushed your probe in slightly deeper, very gently of course, these will be, at least in part, the uterosacral ligaments. So what does deep endometriosis look like in a uterosacral ligament through the posterior fornix? You can see here again, you can see this is the vagina. This you can see is white fibrosis, and within that you can see an irregular nodule of deep endometriosis. To see this closely to the probe, you need to use high frequency, use the highest frequency of harmonics, and then you need to move your focus up so that you're focusing all the beam just here, and it will pop out for you. So we've looked at vagina, we've looked at ligaments. Next we're going to look at deep endometriosis in the bowel. So this is what normal bowel looks like. Again, my probe is in the posterior fornix. The uterus has been pushed over to one side a little bit. And there I've got the vagina and the peritoneum and maybe a uterosacral ligament. Here is some free fluid. And then you can beautifully see the bowel layers. The outer one is the serosa. Then it's the muscularis layer, which consists of two fine dark layers separated by some fibrous tissue. Then comes the submucosa and mucosa on one side, submucosa and mucosa on the other side, then muscularis on the distal side and serosa. So that's one bowel wall, that's the other side, and there's the lumen in between. If you get endometriosis, this is always affecting the muscularis layer here. So you can see this is what it would look like. Normal muscularis coming in, normal muscularis going out, and you've got this lump of deep endometriosis in the muscularis layer just there. So when you start your TV probe, you can track this layer. If you pull out your probe slightly away from the cervix and then look for this line just there. And this line, as I said, you've got white serosa, then you've got two dark layers, the outer longitudinal fibers, a little bit of fibrous tissue, the inner circular muscle fibers. This is the muscularis layer that becomes very abnormal when it's affected by deep endometriosis. So keep your eye on that muscularis layer. You have to move your probe slightly toward the left, up and down, left, right a little bit to keep tracking it. And you can see that you can track that muscularis layer all the way around, and you can usually track it to just about the level of the uterine fundus. And this is what a bowel nodule looks like. So that's the abnormal muscularis, this is normal muscularis, and then we've got the submucosa mucosa, the other side muscularis. And you can see the discrepancy in the thickness of the wall. One's very thick, the anterior wall, and the posterior wall is always normal. And you put some colour on just to check. If there is a lot of vascularity in this, you need to think of a different diagnosis other than just endometriosis. And it's always this side of the bowel, it's not that side. So this is a different patient, again, probe in the posterior fornix. This is the bowel nodule that you can clearly see, with normal muscularis going in and out of it. But what you can also see is this retrocervical fibrosis, and you can see a nodule of deep endometriosis in the ligaments. You can also see that the vagina is normal. It's adherent, but it's normal. And what happens when all three bits of the posterior compartment have deep endometriosis? That's what you can see in this example here. You can see this patient has deep endometriosis in the posterior vaginal fornix. It's fibrosis, retrocervical fibrosis with deep endometriosis within it, just there. And you can see a bowel nodule. And so you can see that both the vagina, the ligaments, and the bowel all have deep endometriosis. And this is palpable on vaginal examination, and gynecologists call this a rectovaginal nodule. So bowel endometriosis, if you can tell the surgeon about the dimensions, about the angle the bowel's making, the percentage of circumference affected, and therefore whether it might be stenosing, how low it is, if it's intra or retroperitoneal, if there are more than one lesion. This is very common either in the same segment or in a different segment, and if there's a rectovaginal nodule. So you can see that ultrasound can see so much more than at laparoscopy. That was the normal pelvis. This is the frozen pelvis. And these are video clips from that patient's ultrasound. You can see that she had a frozen pelvis, that the ovaries, you can see the other way around, that ovary, endometrioma, a little bit of movement, not quite kissing, but also that she had some bowel endometriosis, and that was not visible at diagnostic laparoscopy. Don't forget the anterior compartment. You can look for nodules of endometriosis in the bladder. You can look for smaller lesions and measure the distance to the ureter. And sometimes you get little nodules in the ligaments that come close to bladder but not in it, particularly if there's adenomyosis, and that causes those little nodules too. Look for the ureters. They can mainly be externally compressed from all this fibrosis, and here you can see a hemorrhagic cyst, some deep endometriosis in the ligaments, and this ureter is closely applied and fibrotic to the ovary with a hydroureter above it. And this is a different case, but hydronephrosis occurs in 3% of such patients, so you need to look for it. Always look at the kidneys. Next, we do soft markers, site-specific tenderness and mobility. We go around the entire pelvis looking for mobility and tenderness and ask, is it uncomfortable here or here or here as you go around the uterus, the ovaries, the neck seat, the bowel and the bladder. So a normal scan looks at these things, but we all should be doing the sliding sign and looking at the posterior compartment and the anterior compartment. I draw my findings because I find it easier to remember what I saw. You can see here that there was deep endometriosis at the torus, a little bit in the posterior fornix. Both ovaries had endometriomas, they were kissing. and there's a little bit of endometriosis in the bowel, and I also draw it transversely and tell the patients the ovaries have come down to the level of the torus with adhesions to each other, to the torus, to the bowel nodule, but that the kidneys are all right. I would recommend these resources if you want to learn more about how to scan for endometriosis, and this book is really good. I would recommend that you get that. So I hope that I've shown you that there are lots of appearances of endometriosis on ultrasound, and I'm hoping that one day the NICE guideline in 2000, and who knows, that they will not just consider an ultrasound, but that this will become the gold standard, a detailed pelvic scan once everybody knows what endometriosis looks like. Thank you.